We'll get started. I think we'll probably have a few people still strolling in. This is the pandemic response, and logistics is a big part of that, but clearly running late is not a key priority here. Basically, we've got a great panel here. We're going to make this very informal. We're going to ask lots of questions or give you the opportunity to ask a lot of questions. The format is really to get lessons learned around pandemics and epidemics. I'm Chan from PwC. I'll let our panelists introduce themselves in a second. Just background on myself and PwC, we work a lot and have worked for many years in the international development space in public health. Within pandemics, specifically in epidemics, we've worked with US government, with DHS, HHS, DOD, really looking at the biosurveillance. We've worked a lot with commercial industry, the Gates Foundation, in developing new vaccines and drugs, and work a lot with USAID and other local stakeholders around supply chain as well. So really looking at characterizing epidemic threats, looking at developing countermeasures to them, whether it be diagnostics, vaccines, or drugs, and then looking at last mile response to those epidemics and pandemics, often in a very short period of time, whether it be in the US or whether it be in hard-to-reach places around the world. My background, I'm a pharmacist. I've got an MPH. And an MBA as well. With that, let me have the panelists just do a quick introduction of themselves. I'll start with Alan and then move down this way. So Alan, want to go ahead?
Good morning, everyone. My name is Alan Pringle. I'm with Crown Agents. Crown Agents is a high-impact social organisation that seeks to link private sector commercial agility with a public sector ethos. Our core competencies are around supply chain, humanitarian support, health, program management, and governance, and economic development. They have many years' experience of supporting pandemics, and more recently in Sierra Leone. We've done some considerable work there in support of the Ebola response, which I can talk about a little bit later. My own personal background, I've been with Crown Agents over 30 years now in supply chain. For all of that time, I have a master's in strategic procurement. I spent most of my career overseas. I've lived in Bangladesh, Yemen, Ghana, Zimbabwe, Kenya, and for the last 10 years I've been with the Supply Chain Management System project based here in Roslyn, where I support a portfolio of countries and provide system strengthening support to maybe 10 or 15 countries over the last 10 years.
Great, thanks. Hi, my name is Sonali Corday, and I serve as the Director for Global Health and Development at the National Security Council. Just a brief background on myself. I come to the NSC from USAID, and after a brief sojourn on the Hill, my background before I came here was really working on the President's Malaria Initiative, and in my current role, I really cover a wide range of global health issues across the board, but just given the time that we seem to be in, since I got there, most of my focus has been on the public health emergency issue of the day. So I've spent a lot of time on Ebola and Zika and a lot of the other MERS, a lot of the other things that are popping up and threatening the planet. So.
Good morning. My name is Jamie Butcher. I'm Chemonics Executive Vice President. Chemonics is celebrating our 41st year. This year we're an employee-owned organization. And over the last 41 years have been able to implement more than 1,100 projects on behalf of USAID and other sponsors in more than 140 countries. Most recently, I've been with Chemonics 20 years, and most recently have been able to lead our proposal for the PSM contract, which we're currently implementing, and remain involved with that implementation. Melissa Logan, who's here in the audience, is our Senior Vice President for our Supply Chain Solutions Division, and I'm leading our Global Health Division, which is implementing our Human Resources for Health Cooperative Agreement, both of which relate to our topic at hand today.
Great. So if you think about the last few years, maybe the last 20 years in fact, we've seen substantial progress made in reducing the deaths from infectious disease. So we've seen infant mortality cut in half since 1990, maternal mortality cut in half. We've seen, we're on the verge of eradicating diseases like guinea worm. I think there's 8 patients left in the world. Polio, a handful of cases left. Meningitis A, virtually gone. But yet we see new diseases emerging all the time. MERS, we saw SARS, whether it be West Nile a few years ago, and now certainly Zika and Ebola before that. When we look at the different diseases, we often break it down into pandemic, epidemic, and endemic diseases. Let me ask the panelists in terms of over the last maybe 20 years, 30 years, what have you seen in terms of capacity building, lessons learned, maybe even starting with HIV and how that was progressing and how we responded back to that, but then also maybe looking at some of the diseases that we've seen kind of pop up and occur over the last few years, and also what we can learn from that for what we know will be additional diseases coming up as well. So maybe again, we'll start with you, Alan. We'll come down and just lessons learned, some challenges as well, and then I'm going to open up the audience to maybe ask a few questions on that topic as well.
Okay, thank you. So over the last 10 years since I've been with SCMS working on HIV supply chains, I've seen enormous changes in supply chain. When we started there as an emergency response, many agencies involved each set up their own supply chain and each concentrated on getting things done. Over the years, we saw that evolve to a more developmental approach. And looking back over the last 10 years, I can see widespread improvements in national supply chain capability. Capacity has definitely been enhanced. HIV response, I think, has floated all boats in terms of supply chain. Maybe the most important and biggest impact it's had is on data. When I started working in supply chain, there was not good data at all coming back on consumption or patient information, and supply chains tended to be push supply chains, where quantities were determined at the central level and pushed down the supply chain irrespective of that actual demand. The requirement for data under PEPFAR particularly and Global Fund has really changed that, and systems have now been put in place to collect data, to get information back. We've seen logistics management information systems implemented in just about every country that PEPFAR has worked. We've seen warehouse management systems, which used to be paper-based. They are now almost uniformly computer-based, with warehouse management system, dedicated warehouse management systems, with accounting systems. In some cases, ERPs have been installed under PEPFAR funding, and in one place a control tower in Rwanda has been installed, giving end-to-end visibility to look upstream at what's coming in from suppliers and downstream as to what's being consumed at a country level. So data and systems have improved tremendously over the last 10 years, I would say. Also, I think PEPFAR has enabled a number of important strategic building blocks to be put in place for supply chain. Many countries now have supply chain strategies. Many of them, for the first time, have had a supply chain strategy. Supply chain has been elevated in its strategicness over the last few years. We've seen comprehensive assessments, national supply chain assessments. I remember one was done by Jessica in the audience there, one of the largest ever national supply chain assessments in Burma, where I think it was 280 facilities at all levels were visited and assessed for capability and maturity. I think over 750,000 data points. No one in Burma had any idea what the supply chain capability or maturity was until that assessment was done. And that provided the data to inform the strategy. It enabled us to think about reconfiguring the supply chain, optimizing the network. So those kind of strategic building blocks have taken place in a number of countries under PEPFAR funding or Global Fund money. And that money just wasn't there, that thinking just wasn't there 10 years ago. So tremendous advances, I think. Also, in terms of infrastructure, many new warehouses have been built, many facilities have been renovated, many standards. It's not just the physical infrastructure, but the processes that accompany the infrastructure, the SOPs, the standard operating procedures, the training of the people, the empowering of the people to operate these facilities. And also, I think one area which is quite an area of my particular interest is around trying different models. With the rapid scale-up under HIV, the existing infrastructure could not cope. So there had to be changes, and we've seen things like outsourcing, particularly around transportation, have increased considerably, but also different management models. The old central medical stores model is an obsolete model in my personal opinion. Government managing warehouses and managing assets and vehicles. You don't find that in the Western world. You find the private sector almost exclusively managing supply chains in the Western world. But in resource-poor settings, governments are still owning and trying to manage those kinds of assets. And under HIV programs, we've seen the scale up with demand for improved services, demand for quality services, housing expensive quality products properly in pharmaceutical grade warehouses has become the standard now, and so warehouse management has to go up, and we've seen management models tried, we've seen greater autonomy given to central medical stores, and new models, new ways of doing business have been piloted under PEPFAR and Global Fund programs, and I think that's really encouraging. So in summary, I think the bar has been raised over the last 10 years considerably, and while there's still a long way to go, I don't think supply chain has been elevated to the boardroom yet, which is where it should be, but it's certainly come out of the back room.
Great, thank you.
Great, thanks. So I'm going to just focus my remarks and take a step back from the supply chain issues, but just provide an administration perspective, just based on where I sit at the NSC in the White House. Just to start off, since I got there, which was September 11th, 2014, it was really an extraordinary period of time that was really consumed by public health emergencies. I landed there right in the middle of the Ebola crisis, and the president, just a few days before I got there, had declared the Ebola epidemic a Tier 1 national security crisis, really on par with ISIL and what was happening in Ukraine. And I was really fortunate to work with an amazing set of leaders, from Gail Smith, who I think a lot of you know, who USAID, and I think everyone in this room is really lucky to have her there, to Ambassador Rice, to the president himself, and then subsequently to Ron Klain. And these are people who just really understood the gravity of the situation. And to my mind, having come from development and working on malaria, to have that level of high-level attention paid to a public health issue from the very top of this government's leadership was really quite extraordinary. So just wanted to kind of give you some context on that. And since that period of time, partially because my leadership has been sensitized to these issues, we've really been focused on this question of public health threats, emerging infectious diseases, and how do we really deal with this, both globally but as a U.S. government. And so I spend a lot of time thinking about this with my colleagues. And you know, I think as we've seen in the last 2 years alone, these are not abstract threats. It does seem, I'm sure some people have been watching this carefully, but it does seem like Zika suddenly came out of the blue, Ebola came out of the blue. It defied a lot of expectations. And so we're very sensitive to that. And from my leadership's perspective, the administration's perspective, they've really directed us, and in terms of the U.S. government as a whole, to do more than just play whack-a-mole every time these things come up, and to really take a structural look at how we are looking at dealing with these threats that are going to continue to happen. And we have a long way to go in terms of improving health systems and access to high-quality care and community engagement. So I think a lot of the work that's been going on for the last 20 years is absolutely vital. It has to continue and has to be sustained. But I'll outline just a few other areas that we have been thinking about based on our own experience in the past few years. And the first thing is just, as I said, access to primary health care, support for frontline health care providers, and the system strengthening work is absolutely vital. It's been going on for years, and it has to stay front and center. As we saw really in heartbreaking detail, in any public health emergency, the first line public health and medical responders, they're the first on the scene, they're the first to fight the spread of infectious diseases, they're the first to care who are those affected, and we have to stay focused on supporting our frontline providers. And this also means continuing the hard work that's been going on for a while in terms of advancing healthcare services, everything from clinical care to preventive healthcare to expanding access to medicines to supply chain work. All of that has to be the bedrock going forward. The second, and I'm sure a lot of you have heard a lot about this from our interagency colleagues, but we need to stay focused and ensure that countries are equipped to prevent, detect, and respond to threats. My colleagues often quote that 70% of countries still do not have IHR capacities, and this is why this administration has really focused on the global health security agenda. Well before Ebola and now Zika popped in the headlines, we have been working on the global health security agenda, and this remains an important priority for this administration. And I think, as many of you have probably been noting, we've made some good progress. We made a commitment to assist at least 31 countries to develop and implement plans. We have funding from the Ebola supplemental that is continuing to be used. A lot of the countries are undergoing joint external evaluations, including the United States. We've also agreed to go through a joint external evaluation to measure our own GHSA capacity. And we have a commitment from the G7 to collectively assist 76 countries. And so we are basically pushing ahead on this, both in terms of what our USG assistance is going to do, but really making a strong push on the multilateral front through all of these mechanisms, including the G7. We're going to continue to do that. Third, while we need systems and broad public health capabilities, we also need to treat and target every disease individually. They each come with their own personalities and characteristics. This is why PEPFAR has been successful. This is why PMI has been successful, because they have actually gone after the disease. So we think this remains important. Zika has a completely different playbook than Ebola does. And Zika is also different than malaria, even though they're both vector-borne. They each have their own nuances. And so we can't lose sight of that fact. We still need we still need interventions that are absolutely going after the disease, and we have to remain focused on that as well. And then the fourth is just that we need to continue to have this process of self-reflection and global dialogue around public health emergency preparedness and response. That's really been occurring since Ebola. Ebola really has sparked a lot of important conversations. There's been a lot of reports, a lot of independent studies going on. There's a huge effort going on around WHO reform, and we're very supportive of the steps that WHO is taking. We have a delegation in Geneva right now as we speak at the World Health Assembly that's going to continue to press this conversation. But we're also taking a hard look internally within the US government in terms of how we position ourselves. And I think Ebola and now Zika, it's really taught us that we have different capabilities in different parts of the US government, and we also need to focus on improving our own interoperability going forward in the future. And just one thing that I'll point out, which was a really big lesson for us in Ebola, is that it's really important, I think, to bring the public health communities and the humanitarian response communities together. I think both communities were absolutely vital to the Ebola response, and the more that we can have discussions together, the better off we are. And then finally, this is more relevant really for the NSC, but really no nation is an island when it comes to infectious diseases, and it's kind of cliche to say everything's just a plane ride away, but it's really true. And what we have found sitting in the White House is that anything that starts overseas quickly becomes a two-front problem for us. And so we end up having extremely complex coordination responses, because whatever starts over there inevitably ends up impacting domestic and homeland equities. And this is exactly what we saw during Ebola. This is exactly what we're dealing with in Zika, is we're preparing at home, we're trying to work overseas, and it's very complex. So I think I'll probably end there, and thanks again for coming and listening to me.
Great. Well, I think the thing I can add to the conversation is really to draw on what Alan and Sonali talked about in a couple of ways. I agree with Alan that the bar has been raised in a great way over the last decade or so. If we think about where we were in 2002, 2004, we were really beginning to address HIV/AIDS as an epidemic, and it was a true humanitarian response with a massive investment and effort that was begun. And now we're benefiting from a lot of that infrastructure that's been developed, and the case of Chemonics, we've been able to operate a parallel supply chain in Kenya for the past 5 years, and during that time, address the needs of the patients, 60% of which we were providing ARTs for, and build the systems, ISO 9001 and others, that allowed us to hand over that supply chain to KEMSA, which is the local Kenyan supply chain provider. And for me, it's just one example of many of where that response has been met with a more systematic integration of international standards and approaches that are allowing us to better engage and hand over at scale the work we're doing and in an appropriate way. And we'll see if that ends up working in the long term. It's just happened, and we're hopeful. I think it shows a couple of the challenges, though, that we have working in this area. One is really coordination. I think Sonali talked about the importance of getting together and having these discussions. As infrastructure has been built, awareness has grown, and involvement has grown as well. We saw that with even the Ebola outbreak, where the private sector, Firestone and Maersk and others, began to get involved and provide their assets. That just adds another layer of resource, but also another layer of complexity, and so coordination is critical. In a more granular sense, when I go back to the Kenya example, I think coordination, looking back, would have been something that would have probably improved our opportunity to hand over our supply chain. We were restricted from working with KEMSA, and so the handover happened more rapidly than it probably should have. And I think that's a lesson that we've taken away and that we're integrating into our discussions with the operators of where we're doing parallel supply chains, the folks that should be doing them in the future, is beginning to bring them into those discussions early on to begin to create systems together that can more seamlessly be handed over. I think talking about the data that Alan brought up that's more and more available, I agree. I think there's a long way to go, and if I were to really look at where we need to go, it's more locally driven data sources that are creating a better demand landscape analysis of what is needed where on a more real-time level. And the thing that's great is we live in an era where that's possible. We don't have to imagine that can happen. We actually have many examples of supply chains that have been developed with real-time demand analysis built in, and it's not a far reach to assume that it can be extended in a scalable way into the developing countries we work in. And I think what follows from that then is the last challenge I would bring up, which is really tailoring the solutions that are available, whether they're standards, ISO standards, whether they're technology that allow us to leapfrog infrastructure issues or energy issues, tailoring those technologies that are emerging and beginning to converge in our space to the needs that we see on the ground with the partners that we're working with, so that emerging middle-income economies like South Africa and Kenya are able to take and integrate those technologies, drones or local solar packages or things like that nature more rapidly than next door South Sudan or other places that are lower resource settings and where the package of services and solutions need to be tailored differently. So I think that tailoring aspect, it's not a one-size-fits-all when we're addressing maybe the same disease that has a personality. It may have different personalities based upon the places in which we're working. So we see those as some of the big challenges that we're looking at.
It's great perspectives from the three of you. Let me open up to the audience. I've got some questions as well, but if there's any questions on the opening statements, let me know. In the meantime, let me just ask in terms of biosurveillance, right? So I think that you always say an ounce of prevention is worth a pound of cure. Where do you look at new technologies, processes to look at kind of pre-boom, right? So being able to detect and characterize disease threats. We've heard about using the social media as tools. There's definitely new multiplex diagnostics that can differentiate between emerging infectious diseases, et cetera. Looking at maybe drug resistance as well, whether it be VRE, MRSA, resistant start medicine. Maybe talk a little bit more about what new capabilities are in place around biosurveillance, what progress has been made there. Maybe Sonali, I can ask you first, and then we'll go to the others.
Well, I think you hit the nail on the head that this is so critical. It's so important, and our capacities globally are just not what they need to be. Early detection of any of these diseases is absolutely the key to basically being able to stomp these things out very quickly. And so, there's people who have real expertise on designing biosurveillance systems. But I'll say that one of the key things that has been absolutely vital is really point of care diagnostics, and then being able to feed that into a surveillance system. The development of rapid diagnostic tests for Ebola was really a key innovation that is still sort of playing itself out in the field, but that's really important. But this is a huge issue for Zika for us right now, both globally and in the United States, is we don't have a point of care diagnostic for Zika. So we need better tests, and we also need better serology tests even for Zika. This is, again, like a really major rate limiting factor for us in terms of our response, both domestically, but also in terms of what we can do overseas. And this is really, I think, a key area where the private sector is really important to have that kind of innovation and those partnerships with the public sector to advance a lot of this. This is just a key area for us.
Jamie or Alan, any comments on that?
I can't comment on the biosurveillance. It's outside my area of competence, but I definitely support what Sonali has said about the innovation around early diagnosis and having rapid test kits that can detect the virus early. What we found from a supply chain perspective is early kits for HIV were cold chain dependent. And as soon as they're cold chain dependent, that puts a whole different context on the supply chain and much more demand. So having non-cold chain dependent test kits, being able to get them to VCT centers quickly, it made a huge difference.
Yeah, I think so. I agree that technology provides amazing opportunity and potential. And I was at a conference where Condoleezza Rice was speaking, and something she said struck me. She was in the midst of a panel like this where people were talking about technologies, and she made the point technology is neutral, really. And so in some ways, the technology, we can spur innovation by doing grand challenges with the lab and other places in government that can focus the private sector. And we've seen some of that. We were just the other day meeting with Global Good, which is a science lab created by Bill Gates. Many of you may know it. They've created a cold chain technology called ArcTech, which is amazing. It's like a beer keg that holds ice, and it can hold vaccines at a -7 degrees. And when Ebola was happening, they were challenged because evidently the Ebola vaccine needs to be held at a much colder temperature, and so they invented a gel that could hold the vaccine at -70 degrees for 35 days without any external energy, pulling the vaccines in and out on a daily basis. So technology like that's incredible. I think the other aspect of it that we've got to start looking at, though, is the point of contact with patients and what's happening at the community health worker level. Some of the initial work that we're doing with Human Resources for Health, the cooperative agreement we're implementing, is really providing some astonishing looks at some of the limited resources available. If we took Kenya, for instance, which I mentioned, emerging middle-income economy, if you took the demand that is needed at the community level and the training and resources available, it would take 200 years to train the number of community health workers they currently need. And so when we're looking at it that way, technology really is neutral, because while we can create all of these amazing surveillance and other tools, I think there's also the need to match it with the ability to put them in place and adequately use them. And it's really two sides of that equation that need to be addressed, in my point of view, in order to really be able to fill the gap that Sonali's talking about.
You know, maybe let's get some more detail around that. So I know we've worked a lot with the Defense Threat Reduction Agency around, you know, the diagnostics. It's often used as a forecasting tool, right? So, for example, if you see that there's greater demand for a malaria drug, it may be because the disease is changing, rainy weather, et cetera. There's also certain tools. We've worked with certain agencies looking at if there's demand for Tylenol or, you know, acetaminophen in a certain community. Why is that? Is there a fever of unknown origin? But it can also be looking at chronic diseases as well and evolution of them as well. It can become a commercial opportunity as well. So maybe when you look at forecasting and supply chain, how does that create an input? And I'll ask you, Jamie, first. How does that create an input into perhaps better understanding of the disease progression as well?
No, I think it's the critical link, and it's a bit of what I was talking about with it's the first mile, last mile connection that's been really hampering everyone's efforts. And I think when you look at what's actually happening, in a lot of cases it's an annual meeting with a multitude of donors and government agencies and international community getting together and doing an exercise that is based on mathematical formulas and the fact in order to forecast and understand what the demand is for the supply chains. And Alan knows this probably better than I do and can comment on it. I just think there's massive room for improvement. And again, it's marrying together the technology with the resources available to implement that technology. One example, we're implementing a project on behalf of a mining company in the DRC that's working on community development, and they've asked us to do distribution of rapid diagnostic test kit readers for malaria. The test kit readers are hooked to a cloud technology, so as the test is read, the data goes into the cloud and allows for better analysis of what's going on the ground. So that's great. It's a great technology. It can be used probably better even at borders where you have emerging pandemic threats. But what's missing is an incentive for the community health worker to actually use the test. So the uptake is really the critical space where I think as an international development community we need to step in and really come up with incentives and resource gaps, filling resource gaps and incentive schemes and other things like that that will allow for these technologies to be used to get us the data we need in order to create better decisions. That's
fantastic. You know, Alan, maybe you've got some ideas in terms of, you know, community-based demand planning and forecasting as well.
Well, in terms of the incentives that Jamie was talking about, I think one of the big problems is that far too often data is requested from the lower levels, and it's a chore which is not part of the day-to-day job of the health worker. They have to fill out a report and they send it up the line, and nothing happens. It doesn't change their life in any way. And so being able to get that link between the data that is being requested and improving the working conditions, or not the conditions, but the working practices of the health worker, so that they know if they're reporting a stock out, that there's a response to that report.
Any comments? Okay. Any questions from the audience, please? Hey, we have a runner here.
Thanks. I'm Rosemary Romano. Is that on?
Yes. And where are you
Okay.
from? What organization?
You're talking about some of the technology and all that. Having worked in this business for many years, how about some of the basic issues that come up with supply chain? There's still a lot of places that don't have electricity and don't have any place to store. There's still a lot of corruption in the chain. Things disappear, as we used to say in Brooklyn, fall off the back of the truck. You know, there's still a lot of that technology can't help. So how are you addressing that? How is that, you know, I know it's not just pandemic, it's across the board, but you know, getting a truck in Kenya, I worked on a project in Kenya with supplementary food for HIV patients, and we couldn't get the product from here to there. The product was available. It was, you know, we could transport it, but we couldn't get it from here to there. Is that still true?
Absolutely. And that's where I was, you know, my perspective I'm sharing is technology is neutral. I think we can get caught in a trap of looking at the sexy new solutions and look at how they in concept could overcome the barriers that we're facing, but in reality, it's the health system, the people that are working on the front lines every day working with patients, and the contractual financial mechanisms in which we're engaging them, in which they're engaged by their government or their ministry, that are going to make the difference in terms of allowing us access to the places where these diseases are emerging. And in fact, we're talking about human patients. I mean, really, when you're thinking about a One Health perspective, we also need to take into account, that if we had an ideal world, the human wouldn't be a sentinel case. It would be that we could catch it at an animal level, and that we can figure out where the trends are happening ahead of even that transfer happening. So I think everything you're bringing up is absolutely valid, and is a matter of really continuously creating this improvement model that allows us access to the places in which these pandemic threats are emerging.
Please go ahead.
May I comment?
Yep.
Yeah.
Especially the corruptions, how do you deal with that?
That's a whole conference,
Thank
isn't
you,
it?
Alan, for taking that.
So to link your two comments there, I think one way to help with the corruption issue is around technology, and that's because technology can provide visibility. In the old days of paper systems, no one knew what was in the storeroom unless someone was prepared to wade through piles and piles of paper. But now, with warehouse management systems and ERPs and control tower systems and so on, information and visibility is there. Mm-hmm. And so one example in a country which will remain nameless, I remember there were cancer drugs arrived at the Central Medical Store, the year's supply of cancer drugs for the country. And they were sent to one hospital only and didn't appear on the shelves where they should have done. But there was visibility at the central level that consignment was coming in and where it went to. And so the issue was known. Now, is there the political will and the mechanisms to deal with the corruption? That's another thing. But the technology provided visibility and transparency on the movement of goods, and I think that is a really important factor.
Yeah, let me just add to that from a PwC. I'm not an accountant, even though PwC does a lot of accounting work. What we're seeing is actually reduction in corruption or theft at the local levels because of technology. What we're seeing is perhaps an increase or continuation of corruption at the political levels as well in some of these countries as well. That's almost a harder, you talk about endemic, that's almost a harder challenge to address, while we see at the lower levels in terms of logistics and working in the warehouse that's actually dropped off quite a bit, which is interesting. Right? So.
But I think that endemic corruption, if I could say, is something that, related to what Alan's pointing out, with greater transparency and distributed models of accountability. So, I mean, if you've been reading about blockchain or new ways of accounting for financial transactions that distribute the transparency across multiple nodes, and the ability of that distribution to create something that allows for greater transparency and less corruption, you would think that we're just around the corner from having the ability to massively reduce endemic corruption, but of course in places where there's a willingness to take on treasury management systems and the other things that would be needed in order to make that happen.
All right, good. Please now.
Hi, Deborah Robinson. I'm the academic director of the SIT Graduate Institute here in DC. So my question is a little different. Jamie had mentioned the training needs of healthcare workers on the ground. I'd be interested in your fields, in private sector and government. As young people, we have a master's in sustainable development, come in to your organizations. What's missing in terms of their skills? What are you not seeing? What do they need to have to be effective in dealing with this issue and just kind of in general?
Sonali, you want to take that first if you have a comment?
That's a tough one because right now I'm actually not interacting with that many sort of freshly minted graduates. But I will just say that just because of where we are, people tend to be a little bit more senior. But I think it really comes down to very core skills, even as I'm sort of watching some other folks who are at that, really strong writing. So where I am, the strong policy writing is absolutely a must. There needs to just be an ability, I think, to understand and be open to different worlds. So one of the interesting things I've learned in my job in terms of having to coordinate the entire U.S. government and different cultures within different agencies and different ways of speaking and different lenses and things, the more I think people can sort of learn to appreciate and understand the connective tissue between different kinds of silos and worlds, I think the better off they are and able to function. And just also core quantitative skills are also really important. So although not everybody is going to have to be a super quant, it is really important to kind of understand very basic quantitative things, being able to, like in the public health world, being able to really understand, okay, well, what does this clinical study actually mean? Or what does the supply chain data mean? Or what does a forecasting model consist of? So I think those are the three things that I think are absolutely really crucial from a core perspective in terms of being able to really do well in this field. And it's just going back to the basics and having that strong foundation.
Yeah. Good morning. My name is Megan Wilson, and I just moved back from Benin, West Africa, where I worked for 5 years to run a health program. And there I saw the critical need for supply chain management. And first of all, I wanted to thank the Obama administration and USAID for support for Ebola planning, prevention in this case in Benin, because that really changed the landscape in terms of people's understanding of how infections are prevented, and gave people access to key supplies that weren't really there, like basic things like gloves, etc. But I'm curious from your all's standpoint, being experts, what you think needs to happen in this framework to change the game. Because even in Benin, basic things aren't available. Like we're talking, family planning, we're talking antibiotics, and in rural areas, and even sometimes in big in big cities. So what game-changing thing can happen so that in countries where there isn't war, like Benin, people can have access to these key products? Thanks.
Who's going to take that easy question on?
I think it may relate back to what Deborah was asking about the gap. And I don't know, to be honest, the skills gap. I mean, I think we're in the process of better understanding that. I would be interested from a lab, an international versus national lab perspective. Sonali might be able to comment. But I think that what's missing is the system for community health workers to access training that is provided in a way that doesn't require them to leave their community, which they can't, and go attend a month, annual, long training program. It needs to be bite-sized, relevant, accessible, and I think it needs to be put forward in a way that allows for continuing medical education that is in their professional interests and allows us to draw in more community health workers into the system. I think right now, if you look at what the system, and maybe I'm not sure if this is relevant in the country you're coming from, but many of the countries are a patchwork of donor-funded activities that bring in community health workers that relate to that particular donor. So if you look at the credentials they're able to receive or the information, that certificates they receive, it's from the donor or some sort of patchwork. And I know that Arizona State was sponsoring the conference, and their video is sort of, I think, an example of where I think the international community is heading, which is accessible training that's accredited, that allows for community health workers to gain credentials that would allow them to move up in their career and bring more people into the system. I don't know the exact statistic, I don't have it in front of me, but in Jordan, for instance, where we're working right now, the estimate is that between 2,500 and 3,000 community health workers are needed just to provide for the demand as it exists now. And this is Jordan. We're not talking about some of the other places that have a much, much greater gap. So I don't think it's just skill set. I think it's the systemic approach to providing information, education, access, and professional development that brings more people into that space and allows for folks that are in that space to continue to learn and improve and move into new parts of their career.
And maybe let me just add to that as well, is the role of the private sector. And so I think that when you see, I was in Niger working with the Global Fund, and there was the public side of the supply chain, and there was a private side, and one person had moved over and created their own pharmacy and warehouse, and it was saying how he was getting crowded out by the public sector. And the fact that he could have 5 employees that were as efficient as 50 employees in the public sector, but because of the funding that going to the public sector, it essentially was cannibalizing his business as well. So I think when we look at funding, charity is not sustainable, right? And it can create a level of dependency as well. So I think thinking about funding in an integrated fashion, that's really looking as a catalyst for building up local demand for healthcare services. Once we find that, we'll see that people who are trained locally stay local as well. My wife works at Holy Cross Hospital. I don't know how many physicians, pharmacists, nurses are from French West Africa or from East Africa. The reason is there's no opportunities at home. And so I think that the pharma companies are looking at these markets. Demographics are changing. You're seeing the rise of chronic diseases or awareness of chronic diseases. You're seeing younger population growth overall. And so moving towards that mentality where we're not displacing maybe the public sector, but they're not in competition as well. Certainly you've got to monitor the private sector as well and make sure they're not exploitative. But at the same time, I think that's where you see sustainability. And so I think how we approach the private sector is critical in creating that sustainability for jobs, for awareness of diseases as well, et cetera. So I don't know if there's any comments on that.
No, I mean, first of all, thanks for serving for 5 years in Guinea. That's amazing. So thank you for doing that. That's great, and it's just I'm just in awe of you. So thank you. I would just kind of go back to the previous conversation. I mean, in terms of just a culture of accountability, I think a lot of us who've worked in this field get very frustrated because of some of the corruption issues that we see, because of the lack of accountability, and that can stem all the way up to the top of governments, and it trickles down. And I think that's just a key thing that needs to sort of come into our frameworks and our discussions, and also needs to go from sort of the technical development side into our diplomatic efforts as well, and I've seen that happen more and more. But the issues around transparency, the issues around accountability, the issues around really feeling like there's people who are basically watching your actions, and I certainly feel that sitting in the White House. So, and my leadership team certainly does. So, I think that's kind of one of the key things that I have observed over the years.
You've been waiting for a while for a question.
Thanks. Hello, Stephen Ram with Palladium, and you just actually touched on the question that I had, which was I'd love to maybe expand that theme about private sector for a moment. You touched on it from a financing perspective to a degree. I think private sector in many of these countries, both multinational and national level, are oftentimes large employers and affected by these pandemics in many ways, but they're also, from a fast-moving consumer good and from a market presence where a lot of ingenuity, a lot of innovation is happening. It's not often tapped that well. We're working with private sector distribution companies and a variety of FMCG companies that have deep reach that could be leveraged in a variety of ways. So I'd love to hear from each of you about your perspective on that, where your projects maybe have touched those supply chain networks and leveraged them effectively. Thanks.
Alan, you want to go first?
Okay. I think distribution is one of those areas where the private sector has played an increasingly large role and to great effect, but not large enough. I think there are many more opportunities to use the private sector for distribution, and a lot of the time there's a lack of trust between the government sector and the private sector. The private sector don't think they're going to get paid on time, or they'll have to bribe to get paid, and the public sector think that the private sector is going to rip them off and gouge, and that they're a bunch of pirates. So building that trust is an important thing, and I'll just give you an example of how things can unfold differently between the public sector and the private sector, just on distribution. We were helping the Ministry of Health in Côte d'Ivoire, outsource distribution for their central medical stores. And we ran a tender as an international development agency for private sector distribution companies, and we got bids from 5 or 6 reputable companies, and we selected one, awarded them a contract, and they were doing a great job. Simultaneously, under a different funding stream, the central medical stores took our tender documents and ran the same tender for distribution agents, but for different routes, for Global Fund routes, not PEPFAR routes. So the same tender run by a different entity and different streams of funding. None of the people who bid to our tender bid to the central medical stores tender. And eventually the central medical stores realized their tender was going nowhere. The people who had bid were the people who don't mind paying bribes to get paid. They don't necessarily have the competence or the resources to manage. And so the central medical stores said, this isn't going anywhere, but I can't stop the procurement process. I have no path to get out of this bad procurement. What can I do? And eventually, we had to boot it upstairs to the donors, and the donors spoke, and they spoke with the ministry, and the permission was given for the central medical stores to adopt the same procurement outcome that we had done on our separate thing. But no, I tell the story because it's an example of the lack of trust that exists between the public sector and the private sector. And I think one of the roles that responses to pandemics such as HIV or Ebola, one of the benefits that we can bring is to bridge that trust gap, to model new behavior, to model new arrangements involving the private sector. And I would like to see the private sector involved not just in distribution, that's the easy thing, but there's so much more that they could do. If we could tap into their warehousing as well as their distribution, their management arrangements, their IT, their systems, and do that in a way that is scalable and flexible. Because responses to these kinds of pandemics require a very rapid scaling up, and they require flexibility, something that your public sector is not renowned for. So by embracing the private sector's supply chain expertise in long-term framework contracts, perhaps, that can be scaled, and modeling that with the support of donors to show how it can be done, to help government know how to be able to manage contractors rather than manage assets. I think that would be a good thing to do.
Any other comments? Yeah, go ahead.
I think, I can mention a few other things that are less in the sort of on-the-ground private sector partnerships, but just things that we saw in Ebola. So just continued operations when there is a crisis was very critical. During Ebola, you guys might remember, airlines were threatening to shut down, businesses were pulling out. There was just a mass panic. And I think that there were some steps taken by some very critical private sector leaders to continue to operate. That was really important as well. Also just preparedness for your own staff who's basically working in these countries and making sure that people feel supported and feel protected, and having that kind of conversation with your key agencies that you work with, but in terms of just staff preparedness, response support for your staff, that kind of thing is really important. Business continuity planning is also really key. So when there is crisis, when there is a pandemic, there's things that are, again, shutting down. Even working with local businesses to kind of keep things going, I think, is another key issue. And also just using your voices. During Ebola, but we saw this during HIV, we saw this during various health crises, is that a lot of well-respected private sector leaders would really come out and speak very forcefully on issues in terms of reducing stigma, in terms of continuing to work in these areas, making sure that people who are affected are not isolated. And these private sector voices are absolutely, who are engaging on policy issues, can be really powerful and very effective, much more effective sometimes than the public sector can be, because there's a different sort of constituency and there's a different level of trust. And so I think that's another area to really think about how you engage as well. And I'll just say, there's a private sector roundtable around GHSA, and we're so pleased that this exists. If anybody's interested in joining this, I have contact names. They recently hosted a hackathon for Zika, which I understand is a bunch of really smart people getting together to solve problems. We were just very excited about even this kind of an engagement to try to look at different ways of solving problems and addressing kind of the issues of the day in an informal setting. So those are just some other ideas.
I think if you look at the private sector as well, I think we did a project with the Pan American Health Organization, and they're the largest procurer of vaccines. I think maybe UNICEF is larger, but they were looking at building local capacity as well. So they had a model, which we helped structure, was they had drug shortages as well. So they moved to really managing the market. It was a 3-tier way of looking at it. So they would buy from Indian Chinese manufacturer vaccines for relatively cheap, but they'd often have quality issues, or they'd often have supply issues with that. But that was still the ones they would buy from the most, but then they would have contract mechanisms with the Sanofis, the Mercks, in case there was a shortage, to buy from them as well. At the same time, they guaranteed purchase of vaccines from local Pan-American region drug companies as well, pharmaceutical companies, whether it be in Brazil or Mexico, et cetera, where they would say, if you build a manufacturing facility for a certain vaccine, we'll guarantee you purchasing for 5 years at a certain rate as well. And so there was kind of predictability and demand for that local manufacturer as well. So in that case, they created diversification of the supply of vaccine, of being the multinationals like the Sanofis, the cheaper manufacturers like maybe the Indian manufacturers, and then also building local capacity as well. And it goes back to what you said, Alan, is understanding the procurement process and educating local governments in terms of how to work with the private sector, not looking at them askance, but looking at them in terms of how to create a partnership where there's accountability with delivering the products that they promise as well. But you can achieve a lot by managing the market, so to speak, and relying on the private sector, but not being over-dependent on the private sector as well. So you were going to say something, Jim?
Well, no, I was going to add to what you're saying. I think that, right now we're in a period where we have the opportunity to invest in preparedness. I mean, part of the cornerstone of the GHSA, and sitting in some of the roundtables, I think sometimes we're speaking past each other. There's just different language being spoken by the private sector and government. And it really would take, I think, intentional investment to get to a point of understanding what the different incentives are and putting them together in a way that allows for us to pre-qualify or work through the issues with, contracting, financing, signing off on all of the different things you would have to sign off on in a time of emergency ahead of the emergency. That married together with a better understanding then of the demand needs that are happening at the time the emergency is beginning to happen, rather than the sort of massive supply push that happens, may, from a supply chain perspective, allow us to turn a supply chain back around and give more timely descriptions of what's needed to the folks that are able to provide it in either the private sector, the NGO world, and allow for the response to be more accurate and timely and everything we'd like for it to be. So I think from the standpoint of the global health security agenda, the whole prepare aspect of it is critical. And from my perspective, I think there's a lot of work that needs to be done on investing now to really get alignment with the assets that we all have around what would happen in the time of a response, so that they're prepared and ready to go at that time.
Any other questions, please?
Jackie Fogg, Tetra Tech. I'm just curious about the outreach or partnership with not only our military, Department of DoD, but in-country military and DoD units, because they do have warehouses across the country. They help with security. And I'm just wondering how much of a partnership or engagement is actually going on to improve these kind of systems. They also have things like, they do have mobile warehouses. So they're experts in the supply chain system, and it's a good sort of, I think, a good blend. I'm just curious about that aspect.
Do you want me?
Oh, I can. I can start taking. Okay, sure. Okay, is that my wheelhouse? Okay. I guess I can take this in several parts. I mean, DoD is a key partner, often in humanitarian responses. They often work with OFDA and will provide assets and support in support of a DART team during an emergency crisis situation. We've also seen DoD get involved on PEPFAR programs. They've done some research on malaria. And during Ebola, that was really the most sort of salient example of when the president made the decision to deploy DoD troops to provide exactly what you're talking about, which is logistics support, support to build the ETUs. And in that case, they did exactly what you were describing. They worked very closely, hand in hand, with the Liberian military to accomplish a lot of these tasks. It was a very great partnership. That partnership was very, that was for a moment in time. The DoD did eventually leave once the outbreak came under control. But it's an interesting, I think, area to discuss going forward in the future. I mean, Department of State and Department of DoD, DoD, they do have relationships with foreign military, and they do trainings and a lot of work with their counterparts. And this question of how can, that be used for public health support is an interesting question. I think in some countries it's a sensitive question for obvious reasons. So, it may not be applicable everywhere, but I think it's definitely something to potentially explore.
Any other comments? Yeah, I think the DoD's got incredible capabilities, right? All the way from looking at surveillance, but also to development. The MHRP, the Military HIV Research Program, is one of the largest funders of vaccine development for HIV. They've got a very large malaria program as well. They've got fantastic supply chain capabilities, and that's where you see, I think, the partnership, even whether it's just the USG, looking at CDC, looking at State Department, looking at the DoD, NIH, kind of working in conjunction. We're trying to work in conjunction for these responses, because they often have greater capabilities collectively than the rest of the world does, right? Especially in these developing countries. So there is almost a responsibility for these agencies to work together with local partners as well. And I think they have done in the past very successfully. So I think there's more that they can do in building local capacity. I think there is some skepticism also of the U.S. military in some of these countries as well. And so creating these partnerships appropriately is important as well. And the optics around that is one of the biggest challenges, I would say, based on our experience. Let me just ask, so, we do see a lot of funding coming from the DoD. When we look at the pandemic emergency financing facility, we see the global financing facility. We've got the World Health Assembly going on right now. Where do you see funding flow occurring, and what are some innovative mechanisms to use these financing mechanisms as well? I think often we see, bolstering capacity, transferring of dollars, et cetera, but is there a way to create some innovation around universal health insurance, et cetera, with the additional, perhaps, funding that we're seeing right now, post-Ebola, post-Zika? Jane, you want to go first?
Yeah, I guess the thing for me, in sort of relating it back to the last question, is, is the DoD the first line response that we would want? And I'm not sure that that's, as development professionals, where we would see, I think, the response going. In fact, I think if the DoD gets involved at the level they got involved with Ebola, it's the cases that we failed in preparing and detecting. In fact, when you looked at the statistics, there were 11 treatment units set up, and 28 patients were treated by the time they were set up, and 9 of the 11 never received a patient. So, if we're going to talk DoD, I think it is in the sense of how can that investment spur innovation that allows for, better preparedness and response and detection before we're in a response scenario. And then once we're in a response scenario, hopefully we're better equipped next time than we were with Ebola.
Any other comments in terms of funding and innovative financing mechanisms, hackathons, et cetera? Might be one of them, but other ones. So.
I don't have anything particular to say other than I think as I had said earlier, I think Ebola really has sparked a lot of important conversations, including around innovative financing facilities, for example, the PEF and the contingency financing fund at WHO. And I think in general, this kind of thinking has to continue, and it's important to continue to look at these various mechanisms on how to respond and how to respond it faster. And obviously, having rapid financing available is a key part of that.
Okay.
I'd like to link that question back to the earlier discussion on private sector, actually. Public sector supply chains are enormous. They're dealing with millions and millions of dollars of commodities, and yet government does not invest in the money to manage the supply chain. There'll be a grant or a donation, $10 million, $100 million, but how much is actually put aside for warehousing and distribution? It's rarely enough, and it's rarely enough because the public sector supply chains are bloated and inefficient. If the private sector were running them and charging a fee for service, they would make very sure those supply chains were as lean and as efficient as they could possibly be. So I think there's involving the private sector and having them charge a commercial fee is in itself an innovative mechanism.
Yeah, that's very interesting. So, maybe you first, and then you.
I'm Paige Buchanan. I'm with the Global Business School Network, and getting to this issue of the private sector and sort of an overarching theme that I see going through this is, of course, around management, and not just around management of people coming from the U.S. and other partners, but management by the people who are living and working every day, both in preventive and in response treatments. Scenarios. So one of the things that we're interested in and are working on is building the capacity of local business schools and other institutions to be able to train people to be managers and to make the decisions and build the supply chains and to address these things as they go along. And I'm very interested. I've heard some nuggets that I'm taking note of about what we've learned from Ebola, but as we go into developing more trainings and helping business schools in these regions to have the capacity, what are some of those important lessons? I mean, there are obvious kind of management issues, but what are some of the really key things that the local management really needs to be taking into account and that should be trained? I'm curious.
Any comments, or no?
I mean, my quick thoughts are that, you know, the great news is that we're in a time where international standards aren't just international standards that then are adapted to developing countries or inaccessible by people that you're talking about that are really doing the work. They're completely merging now. So when we're talking with, you know, people that are working in supply chains in a variety of low resource setting environments, they're often Lean Six Sigma, you know, either aware or, you know, certified. They are working on, you know, with CVs where they've worked in organizations that are ISO certified. They're, you know, really aware of what's needed in order to bring whatever aspect of the supply chain they're working on up to that next level. I think then it's on us to figure out the ways and the modalities of delivering the education or the tools and techniques in appropriate fashion. And for me, I mean, online education is one of those opportunities. It's not a panacea. I think there's a lot of research that talks about MOOCs and people starting and not finishing, you know, their courses. But there's some interesting you know, evolution in this area where, for instance, the Global Freshman Academy, we've been looking at that, is an interesting approach where anybody can take courses online. They're available and open to everyone. And once you finish, you can choose whether or not to pay for the course and receive the credit. So I think there's a few things there. One, it's available to anybody. Two, it's online. So if I have broadband and a cheap smartphone, which is beginning to be more and more prevalent, I can have access, and then I get credit. And for me, that's the last piece that's really critical, is that we're giving professionals that you're talking about the opportunity to gain credit and to continue to work into their careers and have professional opportunities as a result. And so I think as you begin to look at business school opportunities, and I really actually should have started by congratulating you. I think that's tremendous, and it's tremendously needed. I would look at not dumbing down the curriculum, not making it less available or exclusive, but going exactly the opposite way. The best curriculum that's as available and accessible as possible to anybody that wants to take it. And I think when we get to that point, we're going to see a shift in some of the countries we work in towards very capable people taking over some aspects of the supply chain, which they rightly should anyway.
Go ahead.
Yeah, and let me just start off by also saying thank you. This is really, I completely agree that this is such important work to do that kind of management training. And I also agree with what you just said, and I think this also applies to your students, is like have them take the hard things. Like don't shy away from the tough curriculum. Like work through it, struggle with it. This is the time to learn and to struggle. Your remarks kind of made me think about a lot of the young people. I do make the time to see people who are sort of early in their careers, and a lot of it as well. I take the math, but it's kind of hard. I don't really like it. Well, nobody really likes taking econometrics, but you kind of have to do it. So I want to just echo what you said. The other thing that I really learned, and there's been discussion, a lot of discussion within the USG, but I think you've also seen the discussion within the WHO reform, is that management during a crisis is a skill and discipline unto itself. This whole concept of command and control and incident management, and how do you make decisions very quickly, and how do you move decision making up and down a chain very quickly from the ground to the highest levels of leadership. There's an actual discipline and a skill around this concept of command and control and incident management, which I think a lot of our emergency management colleagues definitely know and understand well. But that became vital, and we, even within the White House, had a structural change in how we did normal business, and a lot of it involves cutting layers of management. A lot of it means like flattening the decision making, and so that's another thing as you're thinking this through, is to really look into that as key ways to teach crisis response. Another thing that I have learned in my in this position, which again, a lot of our emergency response colleagues, DoD colleagues do, is just this concept of tabletop exercise, and it goes to what Jamie was talking about in terms of preparedness. I've become a big fan of tabletop exercise and having scenarios and people kind of play out how they're going to respond to it, because it starts building both that different languages that people are talking about that you were referring to, and kind of getting people to sort of translate each other's lingo in a non-sort of emergency environment, but then also sort of building that protocol, like what are you going to do when you're faced with really difficult situations. And that could be in an emergency situation, that could also be a really tough situation in terms of, dealing with, corruption or whatever it is. So those are my 2 cents.
Let me just add there, but I think local entrepreneurship is very important as well. There's no better combination than having a technical skill set with business acumen, and we've seen that whether it be in Kenya or even South Africa, where we're seeing small pharmacies and townships. These pharmacists are really good working as a pharmacist, but they're not necessarily good at managing the books, understanding supply chain, et cetera. And you combine the two, even having a hackathon, the Zika hackathon in Kenya, or we saw in Thailand, great examples of the business schools driving that entrepreneurship, because they've got that local context. And so I think that, again, there's no better combination of people understanding the local context, but having the managerial skills to bring an idea to fruition, which MBA programs and business acumen can realize.
If I may just add one thing. One of the things we found is that it's really important to get the training given pre-service. It's one thing to give training on the job, but there's so much task shifting has gone on now. But you have laboratory technicians, you have nurses, all now playing an integral role in supply chain, and they don't get that at nursing school or lab school. So one of the things we found very successful is to implement pre-service training, so they get to understand the basics of supply chain as part of their professional norms, and then they carry that on into their future role.
Great. You had a question?
Yeah.
We have time for maybe 2 more questions or so.
Great. Brendan Miller, Crown Agents USA. interoperability is a theme I've heard sort of throughout the remarks, and I wanted to ask each of you, what do you think is one reachable advance in interoperability over the next 3 to 5 years as we think about pandemics?
I feel like, Alan, you need to answer that question, because it's really hard.
I'll go last if you don't mind.
Do you want to go ahead?
Tell me a little bit more what you mean by interoperability.
If we heard a little bit about incident management, for example. Incident management sometimes happens like an emergency operations center where you're bringing together various parts of the government, the private sector, you're working on a shared platform.
Right.
Sharing information across organizations, coordinating a response. You know, that kind of thing is not new in the emergency response community, but is it something that might be new in the pandemic response?
No, I think I get your point now, and I think it's completely possible in the next 5 years to flip the scenario from a supply push in response situations to a demand pull that would radically improve our ability to prepare and detect. And what I mean by that is, we were talking with the CEO of Maersk at a conference a while back, and he was saying we have the largest port facility in Liberia, and during the Ebola outbreak, it is available, and it was, we could have done so much more than we did, and I think, in talking with him and members of Firestone and others that were involved from the private sector point of view, they were needing clear signals about what was needed, when it was needed, where it was needed, things from a supply chain perspective that are the basics, and from a private sector perspective, drive decision-making and investment. And the good news is there are many examples, in the international community, there's PQMD and the OCHA, Humanitarian Response Information System, American Logistics Network, et cetera, unifying those into a shared platform with the demand creation coming at a micro-local level, working with Ushahidi and others that are developing demand profiles from people in the communities that are then able to give those clear signals to the private sector and the international community is absolutely possible. It requires intentional investment. And I think what Sonali's talking about, getting people around the table with an outcome in mind, but if we were able to do that, I think it would change the equation of the epidemic detection and prevention and response.
Did you have something?
Maybe to comment from a country level, one of the great things about the international community coming together in response to a pandemic is things get done, and the focus is on achieving results quickly. But one of the downsides is there tends to be multiple actors with multiple systems, and the issue of interoperability becomes a problem then. What I'd like to see is a continued and sustained effort to develop national systems, so when actors move into a response situation in a country, they are able to plug into one national system and work through the existing system and not create parallel systems which get stood up and then come down again and then get stood up and then come down again, but rather work through a strong national system. So I guess this is a plea to continue with systems strengthening at a national level and not just at a disease level.
Maybe time for one more question if we have one. Please go ahead. Yeah.
All right.
She has it.
All right, we'll get 2 more questions. I think we have time. Why don't you go first, Lauren,
Okay.
and then we'll...
This works. Okay, great. My name is Lauren Weir. I work for Apt Associates, and I've worked in and around and for PEPFAR for the better part of the last 10 years. I have a question and pulling together a couple different themes from this panel around change management. We had discussed, in crisis control, having a command and control center, and how does that change the way you do business? You had mentioned flattening the layers of decision makers. But how do you get from that change management of this is an emergency, we were very high functioning, to the change management, all right, now it's time to be efficient. Yeah. Now it's about doing the right things in the right place at the right time. And how do you determine that? And that involves bringing in new partners. It involves bringing in the private sector, universities, and all sorts of other different partners to not only find those efficiencies, but to deliver those lasting results. And I think that change management piece is something that we frequently forget about. And I'm curious, hearing from this panel, both in terms of a supply chain, in terms of how do you get the right things to the right place, and not the things that we were sending during the emergency phase, but also in terms of supply being the leader. In the case of HIV, we all know if the test kits don't show up, there's not much you can do to get the population on treatment, and or if they show up in the wrong area. So how can you work through that and really be a leader, considering that you touch all parts of the program in that change management?
Wow, great question. Who wants to take that first?
No, I think, so I can jump in. I think that you're absolutely right, and there's this tension between sort of throwing resources at a problem and then working back towards efficiency after you've addressed it. And interestingly, what comes to mind for me is we were able to speak with people that represented two of the three largest distributors of pharmaceuticals in the U.S. And my guess going into those meetings is that their main focus would be efficiency. And both groups told us, no, it's continuity. It's continuity of the supply chain. It's about making sure that we don't have, that our customers, in this case Walgreens or Boots or CVS, aren't experiencing stockouts, and that we have a continuity that goes all the way back to the API, the basic materials that go into the pharmaceuticals that we're developing. So it began to change our perspective a little bit from one of total optimization of our supply chain to one of appropriate optimization. And so I think when we're looking at, and I'll give you one example, malaria, which Sonali knows much better than I do, when you look at the manufacturers that are providing the ACTs, we're down to really 3 or 4 manufacturers at this point. And I think efficiency may not be the way that we want to move. It is really more continuity of those pharmaceuticals and making sure that we don't have stockouts in the most efficient way possible. And so from our perspective, I think that is, in a time of non-emergency response, where that useful tension can be met.
Let's take one more question, and then we have to close up. If that's okay.
Scott Burgess, Nightingale International. Without money, none of this stuff flows. You guys know that. What rules of thumb do you use kind of behind the scenes for loss factor? You've got breakage, spoilage, you got misappropriation, you got outright theft. So when you hear from the field, you need 100,000 units of whatever it is, and then how many units do you actually have to ship or authorize from DC or wherever to actually get that 100,000 units down to the field, going through all those channels of loss? There's rules of thumb by country, by business unit, by type. Maybe you could put metrics together to have contests and performance levels that if you actually beat your average for your area, then you get a bonus as whoever the supply chain is. So I'm just curious about that.
In the supply chains that I've worked with, we always try to, where we have some, if not control, then some influence. We try to keep losses down due to expiries or theft to less than 2%. But it varies so dramatically, country to country, program to program, commodity to commodity, and also scenario to scenario. If you're in a steady continuity of supply, then it's possible to predict, to forecast more accurately, and to keep those losses lower. If you're in a crisis situation and you're responding rapidly, then you need to hold stocks, you need a highly responsive supply chain, not an efficient supply chain, and you accept the higher losses by having a fuller supply chain and more stock pre-positioned. So it does vary tremendously, but I would say a rule of thumb, if you wanted one for a steady scenario, would be no more than 2%.
I would guess also it depends on shelf life as well, Alan.
Yeah.
Because if you have long shelf life, bed nets, condoms, things like that, you have opportunity to position the supplies in a way that allows you to respond to the unexpected. In the case of blood reagents and things that are down to 75 days or whatever, you're not going to have that. So I defer to you on this, but I think that must factor in as well.
And in some cases, we've seen, for example, ARV schemes where there's an emergency supply has been set up, and that supply is not rotated through normal channels, and because of the shelf life issue that you're describing, Jamie, that those stocks can expire. So it's important for those things with short shelf life, if they're going to be pre-positioned and held as in emergency reserves somehow, they need to be rotated. And if you can make that reserve available to more than just one program, so you reduce the risk there. If you can rotate it through those different programs, then that will be better.
Yeah. I would add that change management, bringing back to that, performance-based financing, or just simply looking at bonuses based on performance can have a huge impact on efficiency as well. So if you're penalized for breakage or stockouts or for expiration medications, you'll see a massive increase in efficiency. Whereas often in public sector settings, not to vilify the public sector, but there's often, why try harder? You're not going to really get punished or rewarded for better or worse behavior as well. And so I think that moving the public sector, nonprofits even, towards more of a performance-based mechanisms can have a huge impact on reducing that. Because in the U.S., I know working as a pharmacist, it's about 0.01%, for expired medications in a pharmacy here, but it increases, rapidly, in other settings with greater complexity.
I think it's not just the people that are working in the supply chain management, but even back to the vendor and vendor managed inventory and some things like that you were talking about, contractual guarantees that allow for an understanding and an assurance that you're going to be able to produce for the next 5 years. Maybe those are the kinds of things that we could look at in the near term that would improve the efficiency.
Good. So lunch is next, so I think we'll close out with that. Thank you so much to the panel members.